Let's set the scene. You've got a 45-year-old patient who started a standard gout medication just 3 weeks ago. 3 days ago, she gets a fever, red eyes, maybe a sore throat. Nothing too crazy, right? Yesterday, a dusky red rash pops up on her chest. But this morning is different. You apply gentle pressure to a red patch, and her skin literally slides right off. Her lips are crusted with blood, and she is in absolute agony. Guys, this is the terrifying reality of epidermal necrolysis. It's a massive medical emergency. So let's dive straight into this explainer and build the exact framework you need to tackle this kind of crisis.
Because look, this condition is a race against a ticking clock. When a patient's skin actually begins to detach, every single hour matters. To save them, we really need to put on our medical detective hats. We have to understand exactly what happens when our body's own immune defenders suddenly go rogue and mistake our skin cells for an invading enemy.
Here's our roadmap for today. 1. The skin failure emergency. 2. Anatomy of an immune attack. 3. High-risk drugs and timelines. 4. Spotting the medical mimickers. 5. Pathology and mortality prediction. And 6. The emergency management protocol.
All right, jumping straight into section 1, the skin failure emergency.
So both Stevens-Johnson syndrome, or SJS, and toxic epidermal necrolysis, TEN, are actually part of the exact same disease spectrum. Collectively, we call this epidermal necrolysis. The absolute key concept to grasp here is that the severity is entirely defined by the percentage of body surface area showing epidermal detachment. We're talking about totally compromised skin. If it's less than 10% detachment, that's SJS. If it sits somewhere between 10 and 30%, we call it an SJS/10 overlap. And once that detachment crosses the 30% threshold, that is classified as 10. The fundamental takeaway for you to remember, this isn't just a rash, this is total skin failure.
Moving on to section 2, anatomy of an immune attack.
Normally, your epidermis is like a sturdy brick wall, and those bricks are your keratinocytes. But in this emergency, a catastrophic overreaction just tears that wall down. Here's how it plays out. Step 1, a trigger, and let's be real, it's almost always a drug, interacts with the body's HLA, the T-cell recognition system. Step 2, this activates drug-specific CD8+ cytotoxic T-cells. You can think of these guys as highly precise assassins that have just totally gone rogue. Step 3, these rogue T-cells migrate straight to the skin and release deadly mediators. The big ones are a protein called granulysin along with FasL. And finally, step 4, this barrage triggers massive confluent keratinocyte death. Basically, the immune system is actively destroying the entire infrastructure of the skin's outer layer.
And this massive wave of cell death, it leads directly to a complete loss of structural integrity. The epidermis physically separates right at the dermo-epidermal junction, creating what we call a subepidermal blister. This is exactly why the skin just sloughs off when you apply that gentle pressure, a classic clinical finding known as a positive Nikolsky sign. Now, interestingly enough, while the outer epidermis is completely wrecked, the dermis underneath is actually relatively quiet. You'll only see a surprisingly sparse inflammatory infiltrate down there. The attack is just hyper-focused purely on those epidermal keratinocytes.
Okay, section 3, high-risk drugs and timelines.
When we see this in adults, it's primarily a drug-induced emergency. Our major high-risk culprits include allopurinol, aromatic anticonvulsants like lamotrigine, carbamazepine, and phenytoin, as well as sulfonamide antibiotics. But check this out. There is an incredibly fascinating genetic link here. Certain populations have specific HLA markers that make them extremely susceptible to these exact triggers. For example, the HLA-B1502 marker puts several Southeast Asian populations at a really high risk when taking carbamazepine. Meanwhile, the HLA-B5801 marker is strongly linked to allopurinol-induced SJS and TEN. But this explosion doesn't happen the second they swallow the pill. The clinical timeline shows that latency usually sits in those first several weeks, typically 4 to 28 days after their very first exposure. Then it's usually followed by a 1 to 3 day prodrome. We're talking fever, sore throat, maybe some red eyes. And then
Then comes the rapid, aggressive onset of dusky, purpuric macules that just quickly coalesce into extensive skin detachment. It moves incredibly fast. We're talking hours and days here, definitely not weeks.
That brings us to Section 4, spotting the medical mimickers.
We have to separate our suspects because a few things can look similar. As we know, SJS and TEN cause full-thickness epidermal necrosis, triggered by drugs, usually in that 4 to 28-day window. But what about staphylococcal scalded skin syndrome, or SSSS? Well, that's triggered by staph bacteria, not drugs. And crucially, the cleavage plane is a superficial subcorneal cleavage within the upper epidermis, meaning there is absolutely no full-thickness necrosis. Then we have DRESS syndrome. While it is also drug-triggered, DRESS features a much longer latency, usually 2 to 8 weeks or more, and it typically presents with things like facial edema and eosinophilia rather than massive skin detachment. So, the ultimate cheat code for differentiating these? Check the mucous membranes. Mucosal involvement, we're talking really painful oral erosions and hemorrhagic lip crusting, is present in the vast majority of SJS and TN cases. It strongly points you toward that diagnosis. If you're examining a patient and they have zero mucosal involvement like you'd see in SSSS, you really need to step back and carefully reconsider your diagnosis.
All right, Section 5, pathology and mortality prediction.
While we primarily diagnose this clinically, you need 2 specific biopsies to definitively lock it down. First, you want an H&E biopsy right from the edge of the blister. This is going to reveal that hallmark full-thickness epidermal necrosis with a sparse dermal infiltrate we talked about. Second, you need a direct immunofluorescence, or DIF biopsy, taken from normal-appearing perilesional skin. In SJS/10, that DIF will typically be completely negative. And that negative result, it's highly valuable because it rules out other autoimmune blistering diseases. And guys, we absolutely have to get this right because the stakes are just unfathomably high here. Historically, the mortality rate for severe TEN sits somewhere between 30 and 50%. Let that sink in. This is a massive, immediate threat to the patient's life. To measure that risk objectively, clinicians use what's called the Scorton system. It calculates risk based on a bunch of factors like age, underlying malignancy, heart rate, and baseline lab values. But watch out for a really common clinical trap. Scorton is used strictly to predict mortality, absolutely not to diagnose the condition itself. You measure it on admission to get a baseline, and then you reassess it around day 3 for improved prognostic accuracy. Finally, Section 6, the emergency management protocol. Listen closely, because this is definitely not a situation where you wait around for a biopsy result before taking action. Step 1 is absolute. Stop the offending drug immediately. Do not wait. Discontinue the suspected culprit, pause literally any non-essential medications, and get that patient straight to an ICU or a specialized burn unit. Every single hour counts. From there, your foundation is world-class supportive care. Because that crucial skin barrier is gone, fluid and electrolytes have to be replaced. But be careful here. The fluid requirements are generally lower than your standard burn resuscitation formulas. You really must guide those fluids based on the patient's clinical losses and their specific physiological response. You'll use gentle, non-adherent dressings, and this is absolutely crucial. Every single patient needs mandatory early ophthalmologic assessment. Even if their eye symptoms seem totally mild at first, ocular involvement is incredibly common, and it can easily lead to permanent corneal scarring and blindness. Okay, let's pause for a quick active recall moment. We've covered a ton of ground today, from CD8+ T cells to Escort-10 to fluid management. But if you remember absolutely nothing else from this entire explainer, what is the single most important intervention in SJS/10? It is the immediate discontinuation of the offending drug. That is hands down the #1 determining factor for this patient's survival. If you stop the trigger, you stop the cascade. And that leads us straight to our core teaching message, neatly summarized in this equation. Stop the drug, plus targeted supportive care, plus early ophthalmology equals your treatment foundation. While fancy immunomodulators like cyclosporin or TNF inhibitors might be considered by expert teams down the line, this core equation always remains your definitive, life-saving baseline. So the next time you see a patient with a fever, a brand new medication on their chart, and a rapidly spreading rash, ask yourself, are you ready to act as the medical detective? Are you fully prepared to spot that mucosal involvement, differentiate superficial cleavage from full-thickness epidermal necrosis, and stop that drug before the ticking clock runs out? Because the skin failure emergency waits for absolutely no one. Thanks for joining me on this explainer, and keep learning.